Hi! Today we are going to talk about the right and left visceral compartments of the thorax, referred to as pulmonary cavities. We will discuss the relationships of the visceral and parietal pleura, localization and clinical importance of the pleural recesses. We'll talk about the mechanisms of development and different types of the pneumothorax, and we'll discuss other pathological fluids that may accumulate in the pleural cavities. You'll see how to remove the air and this fluid from the pleural cavity and learn what nerves are involved in the pain sensation of the pleura. So let's begin. As you may remember, each pulmonary cavity is lined by a serous membrane covered by a single layer of mesothelial cells. We call this membrane pleura. At the root of the lung, pleura reflects from the inner thoracic wall to the surface of the lung and covers them. So we have two layers of pleura lining each pleural cavity: the parietal on the thoracic wall and the visceral on the surface of the lung. The tiny space between these two layers is the pleural cavity, which is normally filled with a fine layer of serous fluid that moisturizes the inner surfaces and smoothens the respiratory movements. You may remember the example with a balloon we used to visualize the relationships of the pleura and lungs. If you push your fist into an underinflated balloon, your wrist would represent the root of the lung, and your fist would be a lung itself. The inner part of the balloon, adjacent to your fist, is comparable to the visceral pleura now, and the remaining outer wall of the balloon represents the parietal pleura. The cavity between these two layers of the balloon represents the pleural cavity. At your wrist, the inner and outer walls of the balloon are continuous with each other, as well as the visceral and parietal layers of pleura, forming the pleural sac. The parietal pleura adheres to the thoracic wall, to the mediastinum and to the diaphragm, and is anatomically subdivided into three parts: the costal part, mediastinal, and diaphragmatic, respectively. The endothoracic fascia separates the parietal pleura from the innermost intercostal muscles. The cervical pleura is a superior continuation of the costal and mediastinal parts of the parietal pleura, which covers the apex of the lung. The cervical pleura forms a cup-like dome, pleural cupula, over the apex of the lung that reaches its summit 2-3 centimeters superior to the level of the medial third of the clavicle. The cervical pleura is reinforced by fibrous extensions of the endothoracic fascia, called Simpson fascia. The membrane attaches to the internal border of the first rib and transverse processes of C7 vertebra. Lungs and pleural sacs may be injured in wounds to the base of the neck, resulting in a pneumothorax, the presence of air in the pleural cavity. The cervical pleura reaches a relatively high level in infants and young children because of the shortness of their necks. Consequently, the cervical pleura is especially vulnerable to injury during infancy and early childhood. The relatively abrupt lines along which the parietal pleura changes direction as it passes, reflects from one wall of the pleural cavity to another, are the lines of pleural reflection. 3 lines of pleural reflection outline the extent of the pulmonary cavities on each side. Starting superiorly from the cupulae, the right and left lines of sternal reflection run inframedially, passing posterior to the sternoclavicular joints, to meet at the anterior median line, posterior to the sternum, at the level of its sternal angle. Between the levels of the fourth and second costal cartilages, the right and left lines descend in contact to each other. The pleural sacs may even slightly overlap each other. Then, on the right side, the sternal line of reflection continues to pass inferiorly till the xiphoid process, that is the level of the sixth costal cartilage, while on the left side, the sternal line of reflection descends only to the level of the fourth costal cartilage. Here it turns to the left and then continues inferiorly to the sixth costal cartilage, creating a shallow notch that mirrors the cardiac notch of the lung. This shallow notch in the pleural sac allows direct contact between the pericardium and the anterior thoracic wall, so-called bare area of pericardium. The costal lines of pleural reflection are sharp continuations of the sternal lines, occurring where the costal pleura becomes continuous with the diaphragmatic pleura inferiorly. The right costal line proceeds laterally from the anterior midline, but the left costal line begins at the midclavicular line to the left of the cardiac notch. Otherwise, the right and left costal lines are symmetrical, passing obliquely across the 8th rib in the midclavicular line and the 10th rib in the mid-axillary line, and becoming continuous posteriorly with the vertebral lines. The vertebral lines of pleural reflection are much rounder and occur where the costal pleura becomes continuous with the mediastinal pleura posteriorly. The vertebral lines of pleural reflection parallel the vertebral column, running in the paravertebral planes from vertebral level T1 through T12, where they become continuous with the costal lines. As you see, the parietal pleura descends inferior to the costal margin in 3 regions, where an abdominal incision might take place. And where exactly these places are: the right part of the infrasternal angle and right and left costovertebral angles, inframedial to the 12 ribs, just posterior to the superior pole of the kidneys. The pleura is in danger here from an incision in the posterior abdominal wall when surgical procedures expose a kidney. If it is accidentally cut in the procedure, a pneumothorax may occur. Projections of the parietal pleura on the thoracic wall do not always merge with projections of the visceral pleura covering the lung. The parietal pleura reaches the mid-clavicular line at the level of 8th costal cartilage, mid-axillary line at the level of 10th rib, scapular line at the level of 12th rib. The inferior margins of the visceral pleura overlying the lungs reach the mid-clavicular line at the level of the 6th rib, mid-axillary line at the level of the 8th rib, and scapular line at the level of the 10th rib, the paravertebral line at the level of 10th vertebra. Thus, the parietal pleura generally extends approximately 2 ribs inferior to the visceral pleura. The potential space between the parietal and visceral pleura is necessary for extension of lungs during inspiration and is the largest in inspiration when the peripheral diaphragmatic pleura comes into contact with the lowermost part of the costal pleura. These pleural lines, gutters or pockets of the parietal pleura, are known as recesses and are clinically important. The costodiaphragmatic recess surrounds the upward convexity of the diaphragm inside the thoracic wall. It forms where the diaphragmatic pleura meets the costal pleura. The costomediastinal recess is the smallest one, and it is located posterior to the sternum, where the costal pleura contacts with the mediastinal pleura. The left costomediastinal recess is larger, less occupied, because the cardiac notch in the left lung is more pronounced than the corresponding notch in the pleural sac. Normally, the pressure within the pleural cavity is slightly less than the atmospheric pressure. Don't confuse the intrapleural pressure with the intrathoracic one. Those are different things. The thoracic cavity is the space that includes the pleural, lungs, and heart, while the pleural space is only the space between the parietal and visceral pleura surrounding the lungs. The relationship between the intrapulmonary pressure and intrapleural pressure is that the pressure becomes more negative during inspiration and allows air to get sucked in. This is so-called Boyle's law, describing the relationship between the pressure and volume. During the expiration, the pressure becomes less negative, but is still less than the atmospheric one, and the air is given out. The only difference between the pressure is that intrapleural pressure is more negative than intrapulmonary pressure. If any of pleural leaves, the visceral or parietal one, are damaged, the air would rush into pleural cavity and lung would collapse. This clinical situation is called pneumothorax. A spontaneous pneumothorax is the sudden onset of a collapsed lung without any apparent cause, such as a traumatic injury to the chest or a known lung disease. Spontaneous rupture of congenital blebs or bulla is commonly believed to be the primary cause of this type of pneumothorax. The air enters the pleural cavity directly from the parenchyma of the lung. In traumatic pneumothorax, the parietal pleura gets ruptured as a result of rib fracture. The air enters the pleural cavity from the outside environment then. Any type of pneumothorax has a potential to become a tension pneumothorax. This life-threatening situation occurs when a piece of injured tissues on the lung surface or on the thoracic wall form a one-way valve. Air can enter the pleural cavity during inspiration but cannot escape during expiration. The atmospheric air in the pleural cavity can cause complete collapse of the lung and a shift of mediastinal structures toward the unaffected side. This will compromise venous return to the heart. The tension pneumothorax requires urgent medical help. First of all, the tension pneumothorax should be turned into the open pneumothorax. That means the soft tissue valve should be removed. Then the perforation of the thoracic wall should be secured. Finally, air should be removed from the pleural cavity and the negative pressure restored. The concept of chest drainage was first advocated by Hippocrates when he described the treatment of empyema by means of incision, cautery, and insertion of metal tubes. But the technique was not widely used until the influenza epidemic of 1917 to drain post-pneumonic empyema. So let's review this clinical case. The patient with multiple rib fractures is presented, and you can see some air within the pleural cavity and the lung is collapsed. So the goal of this physician is to remove this air. So how can we do it? Of course, we need to insert the chest tube and aspirate the air. In patients like this, if the air is within the pleural cavity, the anterior axillary line is an appropriate place to insert the chest tube, and the level is between the fourth and fifth ribs. Remember, all ribs, they converge anteriorly, and intercostal spaces are a little bit narrower here in the anterior side. Anytime a physician is touching the thoracic wall, you can imagine how painful it is. The patient has multiple rib fracture, so we definitely need to anesthetize this area. So layer by layer, skin, superficial tissue, the muscles, we inject the lidocaine between them. Now, the skin cut is done parallel to the rib, the wound is dilated by the hemostat. Pay attention how physician is using his finger to control how deep he pushes the hemostat. And now the tube is inserted, and we even can hear how air escapes from the pleural cavity. The sutures should be applied around the tube just to attach it firmly to the skin, because we are going to leave this tube here for a couple of days, and we'll connect it to the special device which will kind of suck out all the air from the pleural cavity gradually, millimeter by millimeter. And this is exactly what is happening right now. The tube for aspiration is connected to the special device called the drainage canister device. You can see the air bubbles. This is air escaping the pleural cavity. It's an active aspiration. And if we repeat the thoracic X-ray, we can see that lung now occupies most of the pleural cavity. And of course we can check the position of our drainage tube. You can see it here. What else can be found in the pleural cavity? Normally we have just a bit of serous fluid here, which lubricates the pleural surfaces and allows the layers of pleura to slide smoothly over each other during respiration. But the pleural cavity can also accumulate pathological fluids of various kinds, such as lymphatic fluid. In that case, we call it chylothorax, pus in case of pyogenic infection of the pleura. This condition is known as empyema of pleura. If blood accumulates here, we call it hemothorax. Accumulation of aseptic serous fluid leads to development of hydrothorax. If you don't know what exactly is inside of the pleural cavity yet, just describe it as a pleural effusion. To learn what kind of effusion takes place in present case, we need to make a pleural tap or thoracentesis and send the obtained fluid to biochemical laboratory. The results of the biochemical tests will help to make the precise diagnosis. Irritation of pleura by inflammation and any pathological content may lead to formation of pleural adhesions, detectable with a stethoscope as pleural rub. In most cases, the post-inflammatory pleural adhesions resolve almost completely. Some patients are left with minor degrees of pleural thickenings, which usually cause no symptoms or impairments of lung function. Occasionally, the lung becomes encased with a thick fibrous pleural peel that limits expansion, pulls the mediastinum towards the site of disease, and impairs pulmonary function. Such resistant fibrous covering that inhibits expansion should be peeled surgically. The procedure is referred to as lung decortication. The parietal pleura receives somatic afferent innervation from two different sources: the intercostal nerves T1, T11 and the phrenic nerve C3, C5. The intercostal nerves provide innervation to the costal pleura and peripheral diaphragmatic pleura. The mediastinal pleura and the central parietal pleura are innervated by the phrenic nerve. Both intercostal and phrenic nerves have somatic sensation fibers and provide sharp and well-localized pain sensation if irritated. Additionally, these nerves may give referred pain sensation over the shoulder or along the inner surface of the upper limb, as we previously discussed. The visceral pleura is innervated by visceral afferent autonomic nerves via the pulmonary plexus. It generally does not feel pain, but is sensitive to stretch sensation.